This is Dr. Julie Huffmeyer with our open anesthesia intraoperative TEE case of the month for December 2011. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. This month we present the case of a 62-year-old man who presented with a 3-month history of worsening dyspnea on exertion and intermittent palpitations. His past medical history was significant for COPD, obstructive sleep apnea, diabetes, hypertension, and hyperlipidemia. Upon further workup, he was found to have single-vessel coronary artery disease, but also a left atrial mass. He underwent a cardiac MRI, which revealed a 5 cm by 3.3 cm by 2.6 cm mass with central necrosis that was attached to the superior interatrial septum and prolapsed into the left ventricle across the mitral valve during diastole. This is the first TEE image noted on our patient's preoperative TEE in the operating room. Each TEE clip has been slowed and looped repeatedly for study. This may create the appearance of an arrhythmia, which is not actually present. This is a mid-esophageal 4-chamber view at 0 degrees. This view clearly demonstrates an abnormal mass in the left atrium. This large left atrial mass has the characteristics of a left atrial myxoma. It is attached to the interatrial septum, but is mobile and becomes so large as to obstruct the flow of blood. The right atrium, right ventricle, left atrium, and left ventricle are labeled accordingly and appear normal in structure and function in this view. While cardiac tumors in general are rare, a myxoma is the most common primary cardiac tumor, making up 30% of cardiac masses. These tumors commonly arise from the left atrium, but also can be found in the right atrium or in either the left or right ventricles. Myxomatous tumors are usually pedunculated but have a smooth surface. However, they can become friable and embolized to the systemic circulation. The site of attachment for a left atrial myxoma is most commonly the fossa ovalis on the left atrial side of the interatrial septum. Myxomas are slow-growing tumors and, as such, often do not cause symptoms until they're quite large. Most commonly, left atrial myxomas grow so large that they cause a combination of mitral stenosis and mitral regurgitation and can often prolapse down through the mitral valve, obstructing the forward flow of blood. This is a close-up of the mid-esophageal 4-chamber view in order to more closely examine this left atrial mass. Note the way the mass protrudes through the mitral valve during diastole and sits on top of the anterior leaflet of the mitral valve. It is not hard to imagine that this large mass would cause obstruction to diastolic filling of the left ventricle and possibly damage the mitral valve leaflets over time. This is the same mid-esophageal 4-chamber close-up view as before, but with color flow Doppler added in order to get an idea of the pattern of blood flow through the mitral valve around this large left atrial myxoma. As the blood flow velocity increases toward the reduced orifice of the mitral valve due to the myxoma, hemispheric shells in a rainbow of colors are seen to develop. This is similar to the flow pattern seen with mitral stenosis. In addition, during systole, as the myxoma flops back up into the left atrium, there is mitral regurgitant flow noted in the left atrium. The color pattern is important as blue flow is noted when blood flows away from the ultrasound transducer, and the color changes to red when blood flows toward the ultrasound transducer. With increased velocity and turbulence, the colors of blood flow become bright yellow and red with a speckled appearance. Here, blue is seen in diastole as blood flows from the left atrium into the left ventricle around the myxoma. Then, during systole, the flow pattern in the left atrium turns to red as blood flows back toward the ultrasound transducer, which is positioned in the esophagus just behind the left atrium. This is the mid-esophageal mitral commissural view at approximately 55 degrees, again showing the left atrial myxoma from a different angle. The myxoma is seen to prolapse through the mitral valve, but appears very mobile and bouncing in the left atrium. There are a variety of other cardiac tumors, all more rare than the myxoma. Lipomas account for 10% of cardiac tumors and are benign. They are usually found in a ventricular location in contrast to the myxoma. Lipomas are slow-growing as well, and thus can become large enough to obstruct the flow of blood. Papillary fibroelastomas are usually small tumors that originate from valve leaflets and are mobile. They are small with multiple projections and can be a source of embolism, especially as the fibroelastoma becomes larger. Fibroelastomas can be confused as valvular vegetations associated with endocarditis. Rhabdomyomas are a common cardiac tumor found in children, and they are associated with tuberous sclerosis. As with most of the other cardiac tumors, a rhabdomyoma can become quite large and cause blood flow obstruction. A fibroma is a cardiac tumor found in pediatric patients, and it originates from one of the ventricles or the atrioventricular groove. A fibroma often has a central calcification. Cardiac sarcomas are malignant cardiac tumors found in ventricular myocardial tissue. They can become quite large and protrude into the ventricular cavity and surrounding structures. There is extensive vascularity with malignant cardiac tumors. Ultrasound and TEE are useful to visualize this increased vascularity associated with cardiac sarcomas. Metastatic tumors that involve the heart can do so through local invasion or hematogenous extension. TEE is a useful imaging modality in the assessment of cardiac masses. Its enhanced resolution and the ability to position the transducer close in proximity to the structure or cardiac mass of interest make it helpful in diagnosis, especially as compared to transthoracic echocardiography, in which it is often difficult to position the transducer close enough to most types of tumors or masses. TEE helps to identify normal cardiac structures as well as image artifacts that might be interpreted as tumors or masses. As TEE is able to image cardiac structures in multiple planes and angles, it is excellent in delineating the appearance of the cardiac tumor, its vascularity, and its attachment site to normal structures. TEE is helpful in detecting regurgitation or stenosis of valvular structures due to the presence of the tumor near or through the leaflets. In addition, the impact of the tumor on the function of associated cardiac chambers can be evaluated with TEE. Importantly, tumor embolization and thrombus formation are able to be assessed with TEE as well. After resection of cardiac tumors, TEE is vital for evaluating the integrity of the normal cardiac structures that remain, such as interrogating the interatrial septums for lacerations left after the resection is completed. This is the same mid-esophageal 4-chamber view with color as shown previously, but with continuous wave Doppler applied through the orifice of the mitral valve leaflets in order to evaluate mitral inflow velocity. After freezing the image and tracing the spectral profile, the TEE machine software performs calculations as noted on the screen. Although an in-depth discussion of mitral stenosis and its echocardiographic evaluation is beyond the scope of this open anesthesia TEE podcast, briefly, the mean pressure gradient here is 8 millimeters of mercury, which corresponds to moderate mitral stenosis. This is the mid-esophageal aortic valve short axis view at an angle of 43 degrees. The right atrium, right ventricle, left atrium, and aorta are labeled as such. The left atrial mass is seen in this view. It is important to image cardiac masses in multiple views and at different angles to correctly characterize their position, attachment, and impact on normal cardiac function. This is a still 3D TEE image of the left atrial myxoma for our patient. Note its fairly smooth, rounded, or globular appearance. It is difficult to see its pedunculated attachment to the interatrial septum, but indeed for our patient his myxoma was attached in that classic fashion. Here is a post-bypass TEE in the mid-esophageal 4-chamber view with the chambers labeled. The large left atrial myxoma has been resected, and our patient's mitral valve leaflets and cardiac function appear normal. Only one view is shown of the mitral valve here, but it is important clinically to inspect the mitral valve leaflets in multiple views to assess for damage caused by the myxoma. This is again the post-bypass mid-esophageal 4-chamber view with color flow Doppler placed across the mitral valve. There is a normal blood flow pattern postoperatively after the left atrial myxoma has been resected. Blue color flow pattern denotes blood flowing away from the ultrasound transducer from the left atrium into the left ventricle during diastole, and there is no mitral regurgitation noted back into the left atrium during systole. This is the mid-esophageal bicaval view at approximately 90 degrees, although it is difficult to visualize the SVC, which is usually on the right side of the screen, or the IVC on the left side of the screen. This view is used post-bypass after the myxoma resection to carefully inspect the interatrial septum for surgical lacerations or a patent foraminovalle. Color flow Doppler is placed across the interatrial septum to evaluate the flow of blood across any potential opening. In our patient, it appears that the interatrial septum is intact and has not been surgically violated, as there is no blood flow noted across the septum. That blood flow would appear speckled on a TEE with color flow Doppler, as it has a higher velocity. In summary, myxomas are the most common cardiac mass or tumor, and due to their slow-growing nature, they can become quite large before causing symptoms. A left atrial myxoma commonly causes mitral stenosis due to the obstruction of blood flow through the mitral valve by the mass. In addition, some degree of mitral regurgitation may also be seen. TEE is a valuable imaging modality for not only myxomas but other cardiac tumors as well, due to the capability of positioning the TEE probe close to the tumor or mass of interest. TEE is also helpful in evaluating the success of surgical resection of the tumor.